Warning: this podcast does not introduce any new information outside the Foundation's curriculum. Listener discretion is advised.
Hey there, friends and curious minds tuning in. Welcome to another episode of Real Doctors, Real Friends, the podcast that takes you on a behind-the-scenes tour of the world of medicine, one episode at a time. I'm Dr. Roshan Abraham here with my co-host, Dr. Shereen Hamza, and we're thrilled to be the first official podcast affiliated with the Faculty of Medicine and Dentistry here at the University of Alberta in Edmonton, Alberta. Our goal is simple: to create a space where we can explore the most pertinent topics in healthcare, whether you're a current medical student, a hopeful pre-med, or just someone curious about the field. This podcast is for you. And let's be honest, staying up to date with healthcare news is more than just cramming for the MMI or preparing for exams. It's about understanding the ever-evolving landscape of medicine and how it affects physicians. Plus, for all you pre-meds out there, this could be a great way to prepare for those big interviews by diving into real-world topics that matter. So sit back, relax, and let's make this educational journey a bit more fun and a lot less intimidating. This week, we're tackling a topic that's really reshaping healthcare: virtual care. It's almost like the Netflix of medicine, right? You don't have to leave your house, and it sometimes feels too good to be true.
Exactly, Roshan. But unlike Netflix, you can't just binge watch and be done with it. There's so much to consider, especially for folks in rural areas where access to care can be challenging. It might be like trying to find a good Wi-Fi signal in the middle of nowhere, frustrating and sometimes impossible. And who better to discuss this with us than our guest, Dr. Kevin Yang. Dr. Yang, welcome.
Thank you so much for having me, both of you.
With all the hats you wear, from clinical professor to rural health advocate, do you ever get to unwind, or is it all business all the time?
Well, we like to tell each other we work hard and we play hard. So we like to take breaks and take some nice vacations when we can. But when we're here working, we work really hard, long hours, and see a lot of patients. So
awesome. Can you tell us a little bit about your journey to your profession and your current position?
It wasn't a very straightforward one, actually. I never really expected or wanted initially to be a rural physician. I initially started as a locum in Leduc and eventually discovered my passion for emergency and rural emergency medicine. And at the time, the emergency departments were quite full in terms of employment. And so my former preceptor, Dr. Bakshi, who is now retired, but used to work at the university as well, he recruited me to Wetaskiwin, and that's kind of how my career started. So
that's awesome.
And you've had quite the journey, for which I was there for the first little bit of it, right? Because we went to medical school together. Residency was similar. And then we even did locuming like somewhat at the same time, especially in Leduc. I was actually thinking about Leduc myself before I actually came to the university. And so it is a journey. Virtual care has been a game changer, especially during the pandemic. And as most of us have appreciated, especially in family medicine, it's a double-edged sword. What are some of the unique challenges and benefits you've seen, particularly in rural areas, around virtual care?
Yeah, I definitely think it's fitting that you describe virtual care as a double-edged sword. So in some of these topics are exaggerated in the rural community. So virtual care has changed how we practice medicine in the community. We often have patients that aren't able to come in just due to distance or due to weather or, due to frailty. They prefer a phone call, a video conference call. And so now that we have the ability to be compensated for virtual care, that has become quite a bonus for a lot of patients. That said, it's also that patients are quite happy to stay at home.
Yeah.
They feel a lot more relaxed. They're not as anxious coming into the office. Their blood pressure doesn't go up. So a lot of patients just don't want to come in to see the doctor. And I don't blame them. They don't want to get sick, in a busy, crowded waiting room. They don't want to, venture out in the cold, dead of winter. And a lot of them have problems driving and don't have access to a ride. So that's really helped out. Virtual care has really helped out in that respect.
Just to give our listeners an idea about what your day-to-day sort of work looks like, what's your split like? Because you said you did some emergency medicine, you're working out in a rural community. What sort of work do you do on, I guess, say on a weekly basis?
So about I would say 75% of my job is doing rural family medicine. So I'm out mainly in Wetaskiwin running the emergency department and working in the emergency department, seeing patients there. And I generally work a full 20 to 24 hours straight seeing patients in that environment. And then on the days that I'm not in emerge, I'm in the clinic seeing my family medicine patients and doing administrative work, doing some teaching as well during that time period. And then 1 week of the month, I do work in Edmonton, and I work at the major hospitals in Edmonton as well. So
yeah, it's a lot of great flexibility that you're showing off in family medicine. And I think it's great for us to be able to showcase that when we get a chance.
Yeah, no, definitely. I mean, a little bit off topic, but rural family medicine is anything you want, really. You can make it what you want. And, certain communities need obstetricians, GP obstetricians. Certain communities need GP surgeons. Other ones need GP anesthesia, and still others need more emergency doctors. So, depending on the community and its needs, that's kind of where your scope of practice will be. So.
From a logistical perspective, not everybody has the luxury of high-speed internet, and that could make effective communication difficult. So how do you navigate issues like that?
I mean, I think you've answered my question with that, and in that is a big issue is dealing with a disparity of income and disparity of access. In rural communities, there's often poor internet access. And unfortunately, that is actually one of the exclusion criteria to be enrolled in virtual care. Mm-hmm. If you don't have a good internet connection. So, in the major hospitals, we have virtual hospital, and you need an internet connection in order to communicate with the physician team. So, mm-hmm. And, in Wetaskiwin, we are going to be using virtual care for inpatient care, but unfortunately, again, they need internet access. So, that's definitely going to be an issue. I think with satellites, that might help with things, but yeah, I don't know a good solution mm-hmm. around that at this point.
So for those patients, they would have to come in person then?
I think so, or they would need to borrow access somehow. So, mm-hmm. Whether it's I don't know the technology that well, but I think there's ways of getting temporary satellite access to, certain households. Yeah.
Yeah. Not to derail the conversation too much. And I always find it easier when we're actually colleagues and friends from before. What about home visits? How frequently do you see that being done in a rural setting? Because I know for us, even though we work and practice in an academic site, you would think that with our billing structure that as long as we incorporated some, travel time and a reasonable amount of coverage time from other physicians, we could get it done. But it's in fact our faculty work that just makes it hard to actually do those. And I do less and less home visits out in the community and further to that in rural communities. What's it like when it comes to home visits, and are they done anymore?
I think from a physician standpoint, home visits aren't as common, and even among the rural communities, at least in my community mm-hmm. in Wetaskiwin, it's not super common. That said, there are quite a few lodges and assisted living facilities, and it is common for physicians to visit those facilities because they can see multiple patients in one go. It's also not, it doesn't take a very long time to drive from house to house because you're not dealing with traffic. So, there's that advantage with rural communities.
That's
so if
true.
you were really passionate about doing home visits, you definitely could do that. But it's, it's for those that are on an acreage or on a farm that's, 45 miles out. That's kind of the issue. There's also limitations with home care access as well. They have a limitation in community paramedics. They go out to households as well. But again, there is a proximity limitation for that. So, and with virtual health and virtual hospitals, that criteria is in place, that there is a limitation in terms of distance. So one of the barriers with rural virtual care is that people are generally more spread out.
Yeah. I mean, you've highlighted that so well. So obviously the internet can be both a blessing and a curse. So let's dive into the financial side of things, because that's going to impact a lot of what we end up doing, especially in the fee-for-service world. Billing for virtual care, it's like navigating a minefield. How has the shift to virtual services affected billing practices, and what are some of the challenges healthcare providers face?
I think the billing hasn't really changed much that we're able to now do virtual care.
Yeah.
So, but in terms of, comparing virtual versus in-person visits, there's really no big change. So essentially you're paid the same amount, whether you see them in person versus whether you talk to them on the phone. If anything, it might make it a bit easier to see more patients because you can, I guess, make more phone calls in a shorter amount of time than, see them in your office. So there's that advantage.
I might have missed the change, but I thought with virtual care, like with the 0303 CV, I didn't know if we could actually have more than one complex modifier to it.
That's true, I guess. Yeah. So, if you're someone who likes to spend a long time with patients or if that's your style of practice, then virtual billing codes at this point are not as lucrative as in person because you're compensated every 10 minutes. Because
I think you'd be limited to 24 minutes, I guess, with the 15 to 24 minute mark, right? For the 03, for the
I think it's just 15
one.
minutes.
Oh, sorry. No, that's true. It's just 15
for
minutes.
For a telephone call, the max is just 15 minutes.
It's 15 minutes. Yeah.
But that's just for family doctors. I can't speak of what specialists bill from a virtual standpoint. From what I understand, they do quite well. So.
Yeah. But I could see that introducing some challenges if you're limiting your conversations for billing purposes, because you got to keep you up with your overhead. That would limit your ability to provide at least a little bit more comprehensive care in the way of a virtual setting.
Is there a limit to how many patients you can see in virtual care? Or can you just maximize it?
So before there used to be a limit, I don't think there's any limit anymore.
Yeah, that I'm not sure. I'm not sure, but I think
because before
Dr. Abraham's right.
I think there used to be a limit of 5 per day or something like that you could do, but then I'm fairly certain we might have to add a correction because clearly for me working in an academic setting, my shadow billing doesn't seem to matter because I actually don't bill fee for service. I shadow bill, so I pretend bill like a little kid and put in the codes that I think are most relevant, and then we send it off to the government, and the government says, "Okay, you've done your work. Here's your lump sum of money that you all get for the work that you do in an academic center." Yeah. But I mean, it does kind of highlight that billing can be a headache. And we've only touched on one thing and one small aspect, which is the difference between virtual and in-person care. So now looking to the future, what do you think the landscape of virtual care will look like, especially from a rural perspective?
I think the main thing is just incorporating new technology into virtual care. Everyone's already talking about AI, and so I'm not going to delve into that, but that's obviously going to be incorporated into our EMR systems, our health record systems. I'm assuming in the next 5 to 10 years, we'll just be talking to patients and an AI bot will translate that and take notes for us and help us out with our charting. But I think a more immersive environment is going to be necessary to ensure virtual care takes off, because the problem with talking to someone just over the phone is that you take away a lot of humanness of these interactions. And, we talked about double-edged sword. The downside of virtual care is that you don't feel as connected with patients when they're not right in front of you, and when you haven't actually done a physical exam on them. They don't feel like you've perhaps done a service to them. So, and a lot of patients actually prefer to be in the clinic because they feel that there's a bit of a therapeutic relationship. There's therefore a therapeutic response when you talk to them in person and you do a physical exam on them and you take their blood pressure and they can see your facial expressions. So there's a lot of added value to that. So I can't say, everyone is super enthusiastic about virtual care. So going forward, I think that having a more immersive environment will need to happen, whether it's, integrating more of the video technology and that sort of thing. So.
Yeah, I think what you just mentioned really speaks to my next question is, so we've discussed that a lot of patients prefer to stay at home, but at the same time, a lot of patients may miss that direct human connection. So when you kind of distill it all down, do you think patients are ready to embrace this new digital frontier? Like, are we ever going to go full virtual? And you could even add from a clinician perspective, would you ever want to go primarily virtual?
I think if the technology was there, I wouldn't hesitate so much. I think at this point I would still hesitate because the technology is not quite there yet.
Yeah. Mm-hmm.
You know, how do we auscultate someone adequately? And there are systems in place already for that, and they are being employed, but I haven't yet, you know, been offered that technology yet. So it's hard for me to see how that would affect the future if I haven't actually used that technology. Mm-hmm. So I think the technology needs to be more widespread and accessible first before it's that widely adopted. Mm-hmm. So, I mean, for now, telephone calls will suffice for a percentage of patients, but there's also medical legal ramifications with you know, telephone calls, because you know, you could miss, you know, a diagnosis just from talking to someone over the phone. You're not doing any kind of examination, and you know, you can't tell if they're sick or not just from their voice. You know, you need to look at them. So, you know, there's that consideration as well. So I'm apprehensive about fully embracing it, but at the same time, I know it's going to go forward, and, you know, with improvement in technology, I think we can minimize error and improve outcomes. And so far, you know, studies show in terms of virtual hospital care that, you know, there hasn't actually been increased risk of harm, and it's actually been quite successful. So
it's promising.
It is.
Yeah. And I, just to that point, being a clinician, especially having trained with patients, like during your training, it's really hard to shake the stimulus that you get from interacting with the patient in person, and how that actually transmits data for you about that particular clinical encounter. When you remove that physical component, just the inspections, when you were talking about sick versus not sick, the whole inspection piece to a clinical assessment is huge. I find this time and time again that I can walk into the room and be able to instruct my residents or medical students and tell them, this is why I'm worried. There's certain things that they're doing with how they're holding their hands, with how they are moving their head, how they are even just seated. And again, as a family doctor, so one thing is as a physician, you recognize this, but as a family doctor, you know what their baseline is, right? And you've seen that. And we saw this time and time again within our clinic that we did miss a few things here and there. And yet I readily admit that this is something that's an issue for us. And even though I actually do a lot of virtual care. I do a lot of telephone visits, a lot of virtual visits. I like that it's convenient for patients, but at the end of the day, you just can't replace that physical stimulus that you get from the patient about what is happening with them in real time. So I do think it's going to be something that we have to embrace, as you said, but we do need a lot more technology to actually provide us with that certainty of what's actually going on with them. So bigger picture, and I guess this applies to, I mean, this is a discussion that we can all have. I mean, having a role, or what sort of role do you think virtual care will play in addressing healthcare disparities, especially for rural communities and other underserved populations?
Yeah, I mean, we touched on it briefly earlier about the internet access. And, you know, I think if there is appropriate internet access in these rural communities, and especially out on, you know, rural farms and that sort of thing, or out in reserves and underserved populations, if they have access to the internet, then I think we will be able to expand that kind of virtual component. But, you know, unfortunately, a lot of people don't even have a phone line. And so it's, that disparity is still very prevalent, and I would say especially so in the rural communities. So, you know, a lot of my patients don't have a phone line, and they need to resort to either email or secure text. So they don't have any minutes that they can afford. So they can't even do virtual care in that circumstance. So
so then how do we reach them, right? I mean, with so much of our world relying on the internet for communication, how do you reach them? Yeah,
and I've got a vast share of patients who their fixed address is actually the shelter, the local shelter. Right. So, you know, in order to reach them, I have to call the shelter. So it's definitely not, I don't know.
It sounds like it's not just about the technology.
Yeah.
So there's a lot of social and economic factors
for sure
that are involved beyond just internet access.
So then before we wrap up, let's get to a really hard-hitting question. So we're segueing so drastically here. When you feel like a treat, what is your go-to snack or even meal?
Well, my go-to meal is always sushi. I think ever since discovering sushi, I have, spent a lot more money on my meals out because it's generally a little bit more expensive. So, but that's definitely my go-to.
You have a favorite roll or?
No, I actually don't eat rolls. I don't like anything with sauce on it. So it has to be the nigiri sushi.
Okay.
Nice. Good. Nice. What about you, Shereen?
If it really comes down to it, really good bread, like with nuts and seeds, like really good bread, and also very good cheese. And the stinkier, the better. So bread and cheese, that can serve as my breakfast, lunch, dinner, anytime, any place, always.
Should I infuse the Pop-Tart controversy now because we haven't been able to do that yet? No, sure. and my unhealthy obsession with
had
junk
to come
food
up at some
point, right?
You don't look like you eat Pop-Tarts.
Oh no! Very recently, I've tried to avoid a lot of these because of my crippling family history of heart disease. But I would have to say, if I had to pick one particular treat, and not just to keep continuity from our previous seasons, it will have to be Pop-Tarts.
No way.
And that still hasn't changed.
It's your go-to.
It's my go-to. Yes, it can make you feel sick with eating too much or with certain flavors, but there's something about Pop-Tarts. I was just in the gas station recently to pump some gas, and I needed to go in to actually pay.
Don't tell me you bought a gas station Pop-Tart.
I did not, but I was ever so close to it. Like really, really close. It was only blueberry, but I think if it was like pumpkin spice, I'm sure I would have gone for that, right?
So what would you say your current favorite is?
My current favorite? It's still oh my gosh, what's it called? The brown, like cinnamon, what is it? The brown sugar one, I think. Oh my gosh, I can't even remember.
Do you toast it?
So it depends.
He has it down to an art. Was he always like this? That's what I want.
I don't recall.
No, I didn't show this weird side to most of my classmates.
He was still competing for residency.
Yeah, exactly. So I couldn't let that show too much. So I'm pretty sure the way that you're supposed to do it is toast it.
Yeah.
But you do have to leave an appropriate amount of time to actually let it cool. And that usually ends up being, I feel like, depending on how good the toaster is, because it's also the toaster setting that's going to be really important. So you don't want it to be too high. You want it to be low to medium, depending on the type of toaster that you have. I love your deadpan face. This is amazing. And I will usually give about 30 to 90 seconds. I don't necessarily keep a timer anymore because I have kids, but I will give it a little bit of time, but not too much time, so that there is enough of a crispiness to it, but then that the soft inner sort of layer to it, the filling is still brought forward. And so I'd say it does have to be a good Pop-Tart for that to happen. So like some of the new birthday cake type ones, like confetti ones, I was a little underwhelmed by it because I do like that flavor. Okay. So, which is why I like the sort of brown sugar ones, even the cinnamon ones I do like. I don't like the overly like sweet ones, like the fruit ones, because the way that the filling actually cuts through. Yeah. I need something a little bit more tempered when it comes to the sweet inner filling. Bet you weren't thinking it would get that crazy with Pop-Tarts.
That's quite the science.
The only thing that rivals this is Roshan's technique for cereal, and then using the cereal milk to flavor the coffee, I think, was another thing that I learned.
Wow, he's a sociopath. And I'm just trying to remember. We actually did an exam question, I'm pretty sure, on this with Pop-Tarts and blowtorches or something like that. But yeah, it's great to hear that. So sushi, any good sushi places that you'd say are your go-to here in Edmonton?
None in Edmonton. But there's one in Sherwood Park called Kobachi.
Oh, okay. I heard about it.
Yeah. Okay. Yeah. They have a really good fish selection, and I think they must import their fish from somewhere because none of it's local. So
okay.
Yeah.
Wow.
Yeah.
Awesome. Well, thank you so much for sharing your insights, Dr. Yang, and for having this fun discussion with us. I think yours was the healthiest option out of everybody. So
I would agree.
Well, it's very clear that virtual care is here to stay and has the potential to transform healthcare as we know it, but there's certainly a lot of work still to be done.
And we really appreciate you taking the time to chat with us. And to our listeners, we hope you found today's episode as enlightening as we did. Don't forget to tune in next week when we'll continue exploring the many facets of healthcare and medical education.
Thanks for joining us, everyone. If you have any questions or topics you'd like us to cover, hit us up on social media. Until next time, stay curious.